Hello, folks. Thanks for joining us on Head Inside Mental Health, featuring conversations about mental health and substance use treatment with experts, advocates, and professionals from across the country, sharing their thoughts and insights on the world of behavioral health care. Broadcasting on WPBM 1037, the voice of Asheville, independent commercial-free radio. I'm Todd Weatherly, your host, therapeutic consultant and behavioral health expert. With me today is Dr. Ingrid Boveda. Dr. Bovita received her master's and doctoral degrees from the University of Utah and specializes in assessment and diagnoses in clinically complex cases, particularly those involving neurodevelopmental differences. She is the founding psychologist at The Hive Psychological Services, a premier and neurodivergent informed psychological testing practice, as well as the co-founder of Cogenuity, which provides QEEG and neurofeedback services nationally. Dr. B, as she is often called, identifies as neurodivergent, and much of her work is rooted in helping clients and their families better understand their unique profile of strengths and struggles, understanding that some of these struggles need to be contextualized in societal norms of normality. Dr. B personally understands what it feels like when all the pieces do not connect, despite trying one's best. She is intent on shifting society's paradigm of how we help neurodivergent individuals and is passionate about working with families and educating providers, educators, and support persons toward these efforts. Dr. B, welcome to the show. Thanks for joining us.
Yeah, thank you. Thanks for having me.
The thing I was going to ask you about in working with people on the spectrum, because you and I both presented at the last autism symposium conference, not symposium, but the autism research symposium. There's a difference between those. And one of the things that I talked about in mine that you hit on, and I saw hit on in a few different places, was that how, mental health treatment's really failing people on the spectrum a lot, because a lot of people have been treating them the same way, and they've got symptomology that's like that. They've got, they've got symptoms that look like OCD, or they are OCD. They've got symptoms that look like personality disorder, which are kind of misdiagnosed, actually.
Yeah.
They might even have symptoms that people think are thought disorder, but they're not. They're just very deeply rooted in kind of their process and their rigidity and those kinds of things. And then they try treating them in these in what I refer to at times as pressure cookers. They're clinical pressure cookers. It's like group all day and individual therapy twice a week and all this other stuff, and it's too much for them.
Yeah.
Like a lot of them, it's really too much, and for others, like they can track the content and they can teach DBT skills, but they can't use them at all. So, when on the assessment end, how are you dealing with that? Like, how are you putting a grip on that in terms of not only understanding this person's clinical assessment, but also like bringing it to families in a way that they can understand and bringing it to whoever consultant they may be involved with so that they place accurately and put them in a program that can give them the right resources? How does it look from your end, the assessment end, dealing with that?
Yeah. So, and I literally just finished a meeting with consulting group and parent where we were discussing exactly this. So we have a few different things in it, but at the end of the day, someone's test scores actually are kind of the lesser thing we talk about, or the thing that is kind of, we'll discuss it at a 30,000 foot level, unless there's something clearly significant about, for example, someone's cognitive profile. That's usually what I end up not spending a considerable amount of time discussing when I do a review of findings. I want the family treatment team, consultants, and depending on the client, the client themselves, to understand why. Because and this kind of goes to the point that you were making, that we do a great job identifying what the behaviors are, right? They're being defiant to requests, or they're refusing this, or they push people away, then pull them back in, or their mood is labile and kind of all over the place. And we can think, as I mentioned these, we can think bipolar, BPD, right? Like all these different oppositional defiant disorder. Like we can think about all these diagnostic
PDA,
labels.
right.
PDA, right. And then as soon as we, in our minds even kind of assign that label when we think about that person, we immediately look at them from the lens of that diagnostic profile. What we tend to not look at, and this is where the why comes in, is, nervous system wise, what is going on? Medication interaction wise, what is going on? I mean, we are seeing research, just as a minor example, that says that someone who is autistic, the way that medications interact with their brain is different. And that makes sense to me, because the story tends to be they've been on all these meds, none of them seem to really work right. And they tend to create side effects or cause secondary problems. So immediately I'm like, yep, that tracks, right? We are seeing behaviors and we're not thinking about why. So just, and this was part of what I had discussed today. When someone refuses something, is it, we can assume, oh, it's because they are lazy, or they want to test boundaries, or they want to assert control, or whatever. We're not thinking, well, perhaps there's something about the request that has completely overwhelmed their nervous system to the point that it's not that they want to be defiant, it's that they cannot, there's something about the request that is overwhelming to them. Case in point, I worked with an adolescent female a couple of years ago that was in treatment. All she wanted was friends, all the things. She's on the autism spectrum. And there was somebody sitting next to her that was talking very loudly. She had her headphones on and she could still hear them. She took her headphones off and said, "Could you shut the fuck up?" And she, great self-advocacy, right? Number
Didn't
one.
miss a beat.
Yep, didn't miss a beat. The kid did shut up, but she got in trouble. And when the therapist was processing things with the family and with me, because of course I did the testing, and it's like, help us understand why she would do this if she wants friends. The therapist said, well, she is pushing people away, and she is doing this because she wants to, she had this whole thought out conceptualization for why this client had told this peer to shut the fuck up, and implemented consequences and decisions for that student in line with that conceptualization, which was rather punitive. So my question was, is this what the client said they were trying to do? Push someone away, be mean, whatever the conceptualization was. And then she said, well, no, but this person has a history of X, Y, and Z. And I said, no, did you ask? And the answer was again, no. So I said, well, why don't we ask this client what their intent was, what they were trying to accomplish, right? So we asked the client, she's 15 years old, and she said, I just wanted her to stop talking so loudly. Now, of course, it didn't come out right, and so there is some coaching around intent and impact kind of matching up. But the intent wasn't to hurt or to be mean or anything nefarious. It was just, I'm trying to listen to my music and calm down, and there's this really loud talking, and I just wanted her to stop. The way we work with that, the why, right, therefore, is very, very different. And I just see that clinicians, we do this where we make these assumptions instead of asking what sounds like a stupid question, right? Because, the reason is obvious. No, it's not always obvious. Why? What was the intent? And so that's what I try and get people to understand is what the why of the behavior, and how do we work with that, as well as like some of that nervous system stuff.
Clinicians, they have a bit of a problem sometimes, I think, with Occam's razor. The whole like simplest explanation is probably the right one. Why did you do this? Because I
Right.
wanted him to be quiet.
Because I wanted him to be quiet, right? And we're overcomplicating it. Like, this is part of the attachment, or this is part of the,
Yeah.
whatever. And it's like, no, she just wanted them to be quiet. Um, so
Well,
getting everyone to understand that.
well, I think that and to a certain extent, a clinician's value is around their ability to assess things that they're not necessarily told or are not necessarily obvious.
Sure. Yeah.
But it's like if you're always using that as a mechanism, that you're making determinations and putting behaviors in boxes and explaining them or deducing what they mean and so on, without asking, it becomes a practice. And I think this is where individuals on the spectrum have gotten a bit of a raw deal in treatment is that
Yeah.
they, we've assigned a lot of values and some clinical assumptions around what explains certain behaviors. And that might apply. Um,
Yeah.
as a person who's a diagnostician, and all clinicians are supposed to be that to a degree, you go back to the boxes. It's like, well, a person with these behaviors, this one, this one,
Yeah.
this one, this one, it fit inside this box. That's got this label and it means these things. And so I'm using a diagnostic profile mechanism that causes me to understand the root cause of some of these behaviors so that we can diagnose and treat, except for the fact that none of it fits the person that you're dealing with.
Yeah. Yeah.
And then you forget to ask. You forget to
Yeah.
ask, why did you say that? Oh, because I wanted to be quiet. It's like,
Yeah.
well, yeah, let's do some coaching about ways you could ask for that differently. I'm not saying that that's not a need or an invalid need of yours, but let's come up with some ways. And then all of a sudden, you're not treating a malady. You're just coaching some language. It's like, one, it's far easier to do
Yeah.
what we're talking
Yeah.
about than it is to do all these machinations around what is it, a treatment profile and a treatment plan that's going to exercise around this particular condition, all of which is erroneous because no one asked, or just be like, let's use some different words. And I think you get a better response from people.
Right, right.
So,
Yeah. Let's match the intent with the impact a little bit. And I feel
right, right.
like, diagnostic labels are helpful because, to your point, right, like
Sure.
you can then say, okay, here's the profile of a person. But it also, I think, collapses people into overly simplistic ways of looking at them. So if I told you, so and so is autistic, you don't know really what that means because the spectrum is so broad, right? And it really is about understanding that person's profile of strengths and struggles. Versus we might go in and say, okay, autistic. So here's my understanding of their struggles around relationships, their sensory profile, their engagement with their interests, and none of those things might be relevant for that person. Um, you might take ADHD and say that person can't pay attention. And I'm often educating people and saying ADHD is not a disorder of inattention. It's a difference in how the brain regulates attention and allocates its cognitive resources. And when you put it that way, it opens the door to discussing why they're so tired or why sleep is disrupted or why sometimes they don't pick up on social cues because they've got their own thing that they're focused on. It explains so many more things than you're inattentive. So it's kind of like I heard at one point, right? Like I think about diagnostic labels a little bit like stereotypes. And there was an awesome TED talk many years ago that I saw that said, the problem with a stereotype is not that it's untrue, it's that it's incomplete.
Right.
And so
Yeah.
that's how I approach a diagnostic label. It's a good start, but if I told you this person has autism or this person has ADHD, there's a benefit to like, okay, I kind of have like a, script for what that means. The drawback is you run the risk of making that thing that may not even be that thorough, everything about them, their whole
Their
story.
identity. Yeah.
Yeah. Yep.
And I'm working with someone right now, and he said something I thought was really interesting. An individual on the spectrum, an adult who's been kind of dealing with it, said, older. And he said part of the issue that he deals with is that whenever somebody's interfacing with somebody, he doesn't have anything to rely on. If you walk out in the world, we and you pick up on social cues, and you're a person who doesn't struggle with these things, and you can, walk in and start up a conversation, and talk about some general things and walk out and everything else. We have some shared content that we can rely on. We
Yeah.
have some shared understanding around the way the world works. We have some shared ability to pick up on social cues. We have some, or even verbal cues. It's like, this is the beginning of the conversation, and this is the part where we talk about stuff that's not really all that important. This is the part where we say goodbye because this conversation is over. That kind of stuff. A lot of stuff that many people will take for granted. And he said, the thing is that every time I begin interfacing with somebody like this, I start from scratch every time. I have to build a
Oof.
framework for understanding every person and every scenario that I deal with. And it's exhausting. And I'm
That's a
like,
lot of
wow,
data.
that's brilliant. I know, right? Like if all of a sudden it's like you walked into a different country all of a sudden. You didn't speak the language, you didn't know any of the customs, and you know all that other stuff. And every day you woke up, you woke up in a different country, and you had to
Yeah.
figure it out all again. It's like that would be exhausting. And that's how they feel when they walk through life.
Yeah.
And then you put them into treatment where this is their experience of the world. And what they're doing is walking into a group and talking to people all day long. It's no wonder they get fried from that experience. They don't want to do it anymore. They refuse to go to group. Oh, they're not engaging in treatment. It's like, no, you've overwhelmed them, and they're
Yeah.
not benefiting from anything that's here. They don't
Yeah.
feel better, and more importantly, they don't feel safer. And I think that was
Yeah.
another theme that we hit upon. It's like a lot of what a person on the spectrum is dealing with is is safety.
Yeah.
Their nervous system is on hypervigilance all the time because they can't pick up the cues. They're not sure what to expect. Suddenly they're being judged, or they've done something wrong, or they said something, and everybody, they have this kind of trauma, repeatedly traumatizing experience every time they interface with the world. And they just don't feel safe. So if I can
Yeah.
get you to a place where you feel safe, then we might be able to do something that looks like training and coaching, and being able to interface with the world. How
Yeah.
how does that show up in an assessment in your view? Like when you see somebody, like where does it show up in the places where you're looking closely?
Well, there, and this kind of goes with what you were saying. When I think of an autistic person and I think of safety, I think about predictability. And when you don't have predictability, right, you don't have trust. Now that we can argue, right? Oh, well, that's the case with non-autistic people, and sure, right? We all were there for the pandemic. We suddenly our predictability and the world and people dying and say like all of these
Can,
things were
can
awry,
I go somewhere?
right?
Can we fly yet? Wait a minute? Can we
I
go
don't
home?
know.
Should we go stay home? I don't know what we need to do. Right.
Yeah, when will this end? I don't know. um and so I think about that because our sense of prediction, our predictive systems were no longer functional for us. They no longer were something that we can rely on. And so this goes with what you're saying with that person you were talking about, that if you don't have that script where you have to start over every time with everyone, you don't have predictability. You don't have something that you can say, well, this is how I expect this interaction to go. um, so you can't, you then are approaching every situation with a fundamental lack of safety. And in an assessment room, it's very much the same thing. I recognize that I am a complete stranger. Some people don't have a script for testing. Some have had testing before, and that's great. And oftentimes their experience of testing was, at best, it was really boring. At worst, it was, I don't want to say traumatic, but unpleasant, for whatever reason, right? And so I care about doing it differently. I think that there are ways of getting information that don't involve constantly grilling somebody or um, you know help, just the way that they're engaged with testing just for long periods of time. um, and all they want to do is find a connection point. And I used to do this where I would meet with somebody, I knew what some of their interests were, and they would bring something up and I would essentially be like, oh, that's great, and let's move on back to testing. And then when I realized, like, this is how this person is trying to connect with me, which they totally don't have to do, they could just be like, this is I don't like this. When I realized that this is a way that is structured and predictable and more comfortable, a more comfortable way for them to connect with me, it really changed the way that I do assessment, because that for me is crucial, not just for the quality of the data that you get, but you actually get so much more in outside of the questions you ask or the test items you administer. It's like I let parents talk on and on and on, not because I'm like, oh, I don't care, I'm just going to let their mouth run. It's because I actually get so much more valuable information outside of my structured questions from parents. And it's the same with clients. But I try and create as much predictability as possible. Here is what you can expect. Here's what's expected of you. But also that there are going to be some things that I'm not going to be able to explain why I gave this or what the correct answer is or whatever. And there's a reason for it. So if I tell you, oh, I can't tell you that, right, now you understand why.
Yeah, I mean,
Yeah.
I think that for, and as consultants, we look for assessment folks, and, as evidenced by you being on the show, it's like we look for people they can provide us with something that is greater than the sum of its clinical data.
Yeah.
You know what I mean? Like, and people will do this, and you see parents do it all the time. They'll dig into the scores and they'll try to understand what the scores are and try to put something together that looks like their own understanding of what this is. A person who can do a good assessment can do exactly what you're talking about, which is find different ways to information that's going to be really valuable to feed into what this assessment is and can speak to it. It's like,
Yeah.
I don't have a measure for this, but let me point out something that I thought was really, really, important in the time that we spent together. And
Yeah.
and these features came out or these responses came out of this person, and it occurred to me that, that this was important, or they didn't feel safe with this, or whatever it was. And that's
Right.
going to be really critical wherever they go get care, because those people are going to have to pick up on the same thing, figure out a way to like honor it with this person and help them feel safe and move forward. Because if they don't have this, they're gonna put up the same barriers, and they're gonna not benefit from anything that's there, and you're gonna come away with diminished results, if any results at all. Sometimes it's worse when they
Yeah.
come out, right?
Yeah. And,
Um,
and I see with like, and I'm sure you've seen this too, like when a clinician makes a treatment plan, they include like, I couldn't even, like, many goals. And all of these goals are important, right? Like we could argue, I don't disagree with these goals or
so many
these things,
goals.
so many goals, right? But that's another point of overwhelm. I just finished working with a young adult in a transition program that, to his credit, incredibly motivated, wants to figure himself out, wants to get better. But he had these 5 goals, and each of them have these sub goals that he himself made. So his therapist was like, "This is great." Like, thank you for giving me these goals. And now I'll write them in clinical jargon and we'll satisfy that requirement. And it's like, and the talk that this client and I had was, this is all great. Absolutely. But you've got to focus on one, maybe 2 of these while you're here.
Right.
Um, because otherwise, like, you're learning something new, you're trying to do something different. Um, and it's like people, the what I sort of compare that to is like January 1, people join the gym. They completely overhaul their diet, 180 degrees. They start taking the supplements. They start setting their timer to go to bed early and wake up early. Like they're making too many changes that risk it not being sustainable. And so you can't focus on all of those different things. Pick one, maybe two, and start
Yeah.
there and get that going.
Well, and
So
try not to look too far down the road. Like, like be here now, man. You know what I mean? Like, where are we at? Let's be
yeah,
where we're at. And it's obvious that we're trying to get somewhere else. But don't, I think one of the mistakes that you see, that lots of people make, not just professionals in this field, but frankly in any field, and people make for themselves, is they put, the goals, as you say, but they've put this image of themselves or potentially the image of someone else that they're working with in a box. Here's this
yeah,
box of the person that I see that is successful, having completed all of these goals. And and then you get attached to it. And then
yeah,
and then when it starts to not go at the pace you want it to go or diverts, you kind of get hung up about, like, oh, we got to do something else, and we got to move a little faster, and then the
yeah.
person's work centers around them being impatient with how slow they're going towards this mark that they've established, this benchmark or this box this person's supposed to fit in when they get to the end of it,
Yep.
instead of just being with the person. And this happened to me early on in my time in the field, and I had somebody, he was an older adult, a lot of medications. He was very social, liked people. It's like, well, you could do things like be a Walmart greeter, or you could do, volunteer down at the such and
Sure.
such or whatever. He's like, I really just want to be. And this person was, 50 plus at the time. I really just want to be, in a nursing home, because in a nursing home, they did activities. They had
Yeah.
they had medical. They had a nurse that he could see all the time because he spent a lot of time trying to go to the hospital. Something else was wrong with him. He was one of those guys.
Yeah.
And they also had lots of people. So there were people around that wanted to have conversation with people that didn't have a lot of people filling their lives. He knew it was an environment that he would probably thrive in, but everybody kept going, no, you could live independently and you can have these goals and you can do these things. And
Yeah.
we beat our heads against a wall for a year trying to have him fit inside of this mold we had created. And when finally we were like, okay, nothing we're doing is going to go. And maybe he's right. He just needs to go to an assisted living. He went to assisted living. He was happy as a peach.
Yeah.
And he did
Yeah.
actually end up going and doing some things that were different than what he would ordinarily do, but he had the base established. He knew what he needed. And we just
Yeah.
didn't listen. You know what I mean? Like,
Right.
it was a
Right.
huge
Well,
lesson for me in general.
yeah. Well, because we always think that we're the ones with training, we know better than our clients. And I'm guilty of that sometimes as well. And sometimes it's like a lack of trust in that particular person, right? What if what you want is not what you need? Or what if, and we see this a lot with adolescents where it's like, I just want to be home and, do all the things and leave me alone. And in those cases, you're like, no, no, like I need you to trust that I do know better about what you need.
Something else. Right.
You need something other than being a basement baby. And so, but
We can all
there are
agree.
clients. Yeah, exactly. Like the consensus is, clear here. But yeah, there are clients where it's like, they know what will make them happy. Um, so it is. It's a balance, right? Where we're not assuming we know better in every way, every time with everyone. So
We're not saying they don't need help co-creating whatever that is.
right,
It's just that
exactly.
there's this saying, and NAMI has this: nothing about us without us. It's like, like they need to be a part of this process so that they can help guide the thing because it's coming from them, So
Yeah,
they need professional help. We're not arguing that, but some of that professional help needs to also know how to listen and, take different information in and everything else. Um, I, I think that we're looking at a transformation of the field We're getting
Yeah.
a lot more information, and I hope that that's going to translate to a different way that clinicians get trained as well. But,
Yeah.
probably slow, but, when they get out into
Yeah.
the world of the, wilderness and private pay and those kinds of things, I kind of see a different model. And I think that that's probably where it all begins. But,
Yeah.
Ingrid, thanks for being on the show.
Yeah, of course. Happy to be here.
Dr. Ingrid Boveda joining us on Head Inside Mental Health Today. Todd Weatherly, your host. Look forward to seeing you folks next time. Take care.
I feel so lonely and lost in here. I need to find my way home. I feel so lonely and lost in here. I need to find my way home. I feel so lonely and lost in here. I need to find my way home.